My name is Danielle Lavallee. I'm the Chief Scientific Officer and Senior Vice President for Research and Innovation at Michael Smith Health Research BC, and really pleased to welcome everyone this morning. I hope you all enjoyed just a fantastic plenary session. I'm going to be your facilitator for this morning. Before we begin the fabulous presentations that are about to start, a little bit about the format. Each presentations will be about 30 minutes long, with 15 minutes for the presentation and then 15 minutes for Q&A. I need your help reminding me to grab the microphone so that the recording can hear it. So any questions that you have, we'll make sure that you have a mic. I'm pleased to introduce our first team and our first presentation to the podium. So their presentation, Partnership by Design, Building the Community Partner Community in Airways Health Research. So with that, I'd like to welcome Dr. Phalgun Joshi. Dr. Joshi is responsible for functional operations at Legacy for Airway Health, including strategic planning, partnerships, and partner engagement. Dr. Joshi received his PhD in biochemistry from our own UBC and has published in diverse areas, including genomics, gene therapy, drug discovery, and parasitology across several positions in academia and industry. Dr. Joshi has a passion for promoting and ensuring impact of research on patients and priority populations through collaborations and inclusions of diverse perspectives and voices. He is joined by Tony Lanier, who lives in Metro Vancouver and previously spent many years in New York City and Los Angeles, where air quality challenges contributed to worsening asthma. As a member of the Legacy for Airway Health Community Partner Committee, he advocates for early diagnosis, better patient education, and stronger follow-up care for asthma and other lung conditions in British Columbia. And I can personally say I've had the opportunity to work with Tony on some work in post-COVID, so really thrilled to hear the presentation today. So gentlemen, I'll welcome you to the podium.
Thank you, Danielle. Thank you for coming. Again, my name is Tony Lanier. This is Dr. Phalgun Joshi, and we're going to be talking about partnership by design. We're speaking about the building of the Community Partner Committee, which is a group of patient partners. I think there's about 18 of us or so, and we work on research for lung health within British Columbia. We started, 2019, but I'll get into that a little later. One second, I need to power up my slides. There we go. So we thought that we'd approach land acknowledgement, Coast Salish. I love the land acknowledgement today, and one of the things that she brought out is, if you have something on that's from ancestral lands or so, wearing it and actually gives you some form of power or so. There is I don't know if any of you are familiar with, in Ghana, there's a tribe there, Ndikra tribe, that's created Ndikra symbols. And they're beautiful little symbols. One is of a bird, the Sankofa bird, which speaks about going forward, but always looking back to make sure that you're not making the same mistakes. So I love the talk today, and I'm glad that we're here on these lands. I appreciate living here. I've been here for, 16 years now. So we thought that we'd approach building the Community Partner Committee from a different approach. We're going to look at it in terms of building a home. So there's, 5 components to home building that we've chosen. We're going to look at the visioning aspect, and that's the values and commitment, the blueprint, putting out the plan, this is what we think we want, and it should be looking this way. Then the construction piece is where I've come in as a patient partner. And then you look at residing in the home, and that's actually living there and envisioning what you built. And then there's the renovations, because when you build a home, you think it's going to be perfect, but when you move in, you realize that there's some things that have to be changed. And so we'll talk about all 5 of those phases, and so we'll start with Phalgun on phase 1.
Thank you, Tony.
Sure.
All right. So in the visioning part, it's like when you are thinking about building a home, you got to think about what you want the home to look like. How many rooms do you want? How many people are going to live in, and so on and so forth. So the visioning here came at the very front. So when the program was built on a donation that was made by somebody living with COPD, and he made a donation to the Vancouver VGH and UBC Hospital Foundation. And basically, it was a line in the will which said, for research and care of COPD and asthma. That's it. So the because the money was given to the foundation, the senior leadership of VCH, right from the CEO, were really vested in this project, saying this was a chance, because of the little vagueness in that sentence, there was an opportunity to do some blue sky thinking and try to figure out exactly what we want this home to look like. So, these are just some values, over there, but it was to really try to undertake research, try to create an environment where you can actually do research effectively, meaningfully, find ways to develop partnerships that are going to result in impact, right? But one of the things that was central to this leadership group was community-centric, meaning that it's about nothing about us without us concept. So that was a big part of the vision, that the first thing that they wanted to do was create in this ecosystem, create in this sandbox for all these kind of collaborations and research, what is the system that can be created where patients can be engaged meaningfully, effectively, and also what was important was that the patients play a role in informing and educating and increasing awareness of the other interested parties. So I was the first hire, by the way, and I came from the spinal cord injury field. I used to work for the Rick Hansen Institute. And in the spinal cord injury field, the patient's voices are very loud and, very meaningful. And because, they're similar, those of you who remember doing HIV, the HIV patients were really activists, right? So they came with that, so I brought those kind of values into what my intent was to bring those kind of values into lung health. So so the next step was the plan, the blueprint. We wanted to try to create a plan. So there were 4 things we laid down and said, we need to address this right away, straight off the bat. So the first thing was developing partnerships. Now you can imagine just myself working on, I was the first employee. So I talked to our senior leadership, and the senior leadership said, focus on getting patient engagement. I said, yes, right? That was just music to my ears. So we built partnerships. So the first group we went to speak to was the BC support unit, right? They were at that time working on patient engagement, so they were just the ideal partners. So Lynn Fian, many of you might know her, Larry Moroz, I had them on speed dial, and they were so generous with their time. And then the other person was Alison Hoons, who's in the room here today. She was the KT broker, a knowledge translation broker for VCHRI at the time. And because our program was under VCHRI, she was kind of seconded, or we were able to borrow her time to help us with this work. And then Patient Voices Network, we engaged them. And VCH has this community engagement advisory network, KEEN. So we reached out to them as well. And we were always talking to them all the time. And they were so generous with the time. And because they saw the commitment from senior leadership, that actually gave them an incentive that, this was important. We really mean what we talk about. Second was developing a terms of reference, very clear. And this is, again, the help with all those people on that list there. What is the expectation of this group, of the CPC? What is the expectation of the patient partners? What are the expectations of the researchers? What are the expectations of legacy, right? And, in terms expectations, meaning like what are the functions, how much time, we made a commitment that we would actually be respectful, like, some of the guiding principles of integrated knowledge translation were applied there, how communication was going to happen. And that was just a starting point because our terms of reference have changed as well. Then the third part is patient recruitment, recruitment of patient partners. So what you have there is a list. So we cast a wide net, right? We wanted to find and honestly, if somebody asked me which was the most effective way, I would say actually the other CPC members was the most effective way. So the ones who had come in recommended other folks. And in a way, it was validation for us that there was people who believed in what we were trying to do. Then the fourth thing, which is making sure that there was somebody for who patient engagement was a full-time job. It wasn't something you did on the side of your desk, right? And we were looking for very specific skill sets. And I have to be honest with you that it wasn't that easy. We had people who applied for this position who claimed that who thought they were patient engagement experts, but they were not, right? For example, recruitment for a clinical study isn't patient engagement, right? So we had to be very careful about, who we hired, and we were really blessed that so far the people we have hired have just worked out really well. Right, and then the other thing was we developed processes, right? And this was part of the blueprint. which is that it might seem trivial, but there are little things behind the scene which you have to take into account. So for example, all right, so you have a patient partner, you go to reimburse this patient partner. We work under VCH. VCH has really stringent policies about how money can go out. So many patient partners, you give them gift cards. And gift cards, giving out gift cards in a public funded entity, and some of you might be aware of it's a minefield. So we actually had to get permissions, we had to have accountability, we had to have accounting, we had to go into so many details. And this are administrative, I would use the word burdens, but they were necessary burdens, right? And then the other thing is the governance. So this committee, we had a transparent way of electing co-chairs. And there were we right now have subcommittees. One subcommittee led by patient partners around training. Another one we have is on recruitment, right? Communications, we were very clear about communications, and there was a constant evolution of that as well. I just want to talk about this coffee chats for a second. A lot of this happened during COVID in 2020. And many of our patient partners felt disconnected because, the recruitment happened through Zoom and so on. So they said that, they were feeling homebound. Is there a way for them just to get together virtually and just shoot the breeze? And I honestly did not see the value in that, not being a patient partner, but I really began to see the value as this meeting started happening, because it gave these patient partners to connect with others, living with the same kind of experiences. But most importantly, there were some lifelong partnerships and friendships that have developed, that even when these patient partners were no longer part of the CPC, there was still buddies, right? And then training was obviously important. We actually had to figure out a way of how to connect researchers. So when a researcher came to you and said, hey, I want a patient partner, we said, hold on, right? What does that mean? So we did a number of those things. And then finally, the evaluation, we wanted to make sure that evaluation was always in place. All right, now I'm going to pass on to Tony to talk about his experience.
So this is the construction piece, and this is when patient partners came to play. So I joined, quick story, I came through the back door being a patient partner. I was a patient participant because I was one of those hundreds of thousands of unlucky British Columbians who did not have a physician. And I was receiving my health care from walk-in clinics. And as many of you know, that they are well-meaning, but unfortunately the quality of care lacks continuity. And so I had to actually find other ways. And so I found I think it was a notification downstairs in at VGH, in the research building, and it says we're looking for patient partners for asthma. And so that's how I actually got to see a doctor. That's how I got to see a respirologist, and somehow my name bubbled up, and I received a call from Phalgun. And Phalgun mentioned that he was building this community and that, it would be great for you to participate if you're interested. And I said, absolutely, sign me up. So I walked in the door with, 21 other patient partners. And the one thing that we had in common is that we didn't know what POR was. We had no idea. So we had to learn all of that. And so this is where the work went into play. I'm going to just read out a couple of the people who were involved here: the BC Support Unit, Patient Voices Network, VCH Community Engagement Advisory. Allison was there as the KT broker. Dr. Patty Daly was there, and a number of other individuals, researchers, clinicians were there on day one. And so I knew that there was a lot invested in this program. And so we had to do some big things. We had to, first of all, learn what we were going to be doing. What is POR? How does this all work for us? And what do we learn? Now, I don't know if you noticed, maybe next slide, the date here was actually in 2019, and that was actually during COVID. And so we had to reconnect somehow, but BC Support Unit put through a 3-day elaborate training program on POR that gave us the ability to move forward and start the work. It was a lot of hard work, but again, with some of the people that were here to help out. And I just want to, again, say, Allison, as a knowledge broker, when you're a patient partner walking in the door for the first time, you don't really have permission to speak. And so you sort of need that permission to come out to say, hey, I can ask questions here. But Allison, I think, taught us how to do that. So what we've done since then, we represented 5 health authorities, engaged in 38 projects, 8 of which are external, almost 3,000 hours of work, $9 million in funding and grants, knowledge translation and advocacy. We've done strategic planning, and we actually partner with a number of other organizations, such as BC Support Unit. We've worked with them to build this roadmap. Don't look at the roadmap, though, because there is a new version of the roadmap being presented right outside. And so make sure that you see Hero about that. We partnered with, again, Len Frean to help us out with the training and support, VCH Research Institute, Alberta Support Unit, LAH Governance, and we did the LAH Care Summit that took place over a period of 4 sessions in 2022. So we've learned a whole lot about that. Okay, so these are some ongoing challenges.
No, I have 1 minute. So I'm really going to go through this, but basically our biggest challenge here is increasing representation. And the other one is changing the mindset of researchers. This is an uphill battle, and it's something we are working really hard to do. Let's see. All right, lessons learned. I think this is Tony. You want to just 30 seconds?
Okay, yeah, lessons learned. And we got a whole lot of these things, buy-in, definitely getting people to understand the process, things that we're doing. How do you fund your engagement? Are people being compensated appropriately? Being flexible, because we've had to make a lot of changes. The other thing we had to do is evaluate what we're doing. Every now and then, we had to be pulled back to the table to say, hey, we're patient partners. What are we supposed to be doing again? So that's actually quite important, and it does take a village. And so I think we're out of time.
Is this on? Okay, perfect. If you want to stay at the podium, I'll walk around for questions. Does anybody have a question off the top? I will do facilitator prerogative as I come over here to this person. The evaluation, can you pick up with the evaluation piece? I noticed that you used the Peers 22, which was actually developed here in BC as well. Is that data that you've used to evaluate how things are going? Tony, you mentioned evaluation, or has it been more amongst yourselves in that?
Multiple evaluation, and that's actually a good point. We have used the Peers 22, but we've also evaluated how we're doing as patient partners, and do we still understand the game plan? Do we still understand after 5 years now what we're supposed to be doing in terms of partnering with researchers and having the ability to have these conversations, and sometimes they're complicated conversations with investigators where we have to really say to them, help me help you with your research. And so there's always areas, but yeah, Peers 22 is definitely in there. Did you want to add something?
Yeah. So just wanted to, we have an acknowledgement slide here. So Cleon Hamilton, is the developer of it, and Allison. Oh, there he is. Hey, Cleon. Nice to see you. Yeah, so Cleon and Allison were both part of that project as well. So yeah, we benefited from that, but I think the other thing is that we are doing another evaluation right now, where we're actually using the PPF. Many of you might know this is Patient and Public Engagement Evaluation Tool. So it's more, so what we're using that to evaluate from a researcher's perspective as well, that what are the researcher's perspective and how patient engagement actually works. So this is something we plan on doing regularly.
Perfect, and thank you for modeling good behavior on acronyms. PEER is Patient Engagement and Research, so that tool was developed by Cleon and colleagues. Christina.
Great. Thank you, Phalgun and Tony, for this is great work, and it's so comprehensive in a few years of what you have accomplished. I was interested, Tony, you mentioned how when you first walked into the room as a patient, you felt like you didn't have the permission to ask questions, and then you have Allison opening up, teaching about Katie. And so can you share a little bit on how you felt comfortable in asking questions? What was it that help you help
Yes.
other patients? Yeah, thank you.
The acronyms. I mean, and there's a lot of acronyms. I'm from a business standpoint, so I have no experience in health research. And so when you're sitting in the room and there's these amazing people around you and they have health experience, and they're having a conversation, it almost feels like the conversation is happening around you. I'm a Googler, so I'm there Googling up terms, and and I can only type so fast. So sometimes I end up losing, one definition over looking at another. But having the ability to have a knowledge broker in the room, where that individual will stop the traffic and say, hey, can you explain what that is? I'm not sure what that acronym means. Can you tell me what that means? And that actually gives you the ability to say, you know what, I guess I can do that for myself. And, and you don't get, nasty looks for slowing things down, but, it's always nice to have someone who's experienced in that, teaching you how to open the door and ask questions for yourself.
Thanks, Tony. And just to underscore that, I'm a pharmacist from the States. APHA is either the American Pharmacists Association or the American Painted Horse Association. So you have to be really careful for what you type in. Sunny?
So how many horses do you have in your stable? Thank you. Excellent presentation. I grew up with asthma, junior onsets, and I was fortunate not to have had symptoms for years, so it's great. I'm going to give you my minute. I'd like to just get more of your thoughts on the getting researchers buy-in. Any thought on how to do that and successfully do that? That's one of the challenges patient partners do have.
Okay, I'm going to get into trouble for my answers, but so I think I'll give you this is not talking, I'm not talking on behalf of Legacy Airway Health, just my observation here, is that there's one group of researchers who are hopeless. Like there's just no chance, right? They see patient engagement as a checkbox, for a grant application, and that's all that matters. But then there are these other researchers who actually need, when they get exposed to patients, like actually interacting with patients. So for example, I'll give you one example. We have a health economist who was sitting in a meeting with other patients, and one patient said that, the out-of-pocket costs for asthma drugs are really significant. So this health economist actually took that to heart and has developed an entire research project around out-of-pocket costs, right? And has patient partners involved in the project. So I think that's one end of the spectrum where, you get exposed. I think often sometimes it's not knowing what you don't know. And this higher up you are, you've succeeded, without any patient engagement. So this is just a pain in the, whereas I think the people who are coming through now, the early career and mid-career, I think they're more open to and more sensitive to patient engagement. So I don't know if that answers your question.
It does. I think the challenge is, of course, exposing these researchers to patient partners, because if it takes them having experience with patient partner to get their buy-in, but they're not getting exposure to the patient partner, is a catch-22 situation.
Show of hands, do we have any research trainees in the room? There we go. That's going to work. Yeah. Kent.
Yeah, maybe just a little different direction. I wondered how successful this particular group has yet been in using your interdisciplinary approach to help get research findings into common practice to improve asthma care.
That is an excellent point. We are hoping to reduce that 17-year gap from knowledge to change, narrow it down, but I can just give you one example. So for COPD and asthma, there's quite a bit of information already out there on what are the best practices and so on. So we did quite a bit of qualitative research and some engagement focus groups and so on, and trying to understand what are the barriers for implementation of some of these things. And Tony was a co-chair of this group that was overseeing this effort. And we did knowledge translation. We went to senior leadership of VCH and made a presentation to the executive team. So the CEO was there, the CFO, and they were all there. And Tony actually gave a presentation. And they actually moved on it and there's an active COPD group led by directors moving this forward. So that's one example. The second example I can give you is that wildfire smoke is a big issue around BC. And Dr. Chris Carlston and his group are currently working on developing messaging. What is the most effective way to get affected communities? So first of all, learning where do these affected communities get their knowledge? And what do they do with that knowledge? So that's an example of having some kind of an impact.
Just to add also, we've lost a patient partner because of the length of time of health research. And he left, he was really angry because he didn't understand that it would take that much time to actually move things. And so it is a challenge.
So can I just add one other thing? What Tony just mentioned is one of the most heartbreaking thing, that I experience in my role. When we have patient partners who are committed to helping us, part of this group, and they pass away. And we feel that, I personally feel sometimes that, this is a missed opportunity, right? Because we know what could have been done to prevent it. Why did the health system not follow up on what, why does it take so long to implement some of those things? So anyway, that it impacts us as well.
We have time for one more question. Yeah. Bring us home.
Hopefully you can answer this question pretty fast. Where do you see the advancements in artificial intelligence with the research with this?
Tony, you want to take a stab at it, or shall I?
I have to think about that. That's really interesting. I can see it working in training and development, just from where I sit. But that's a good question. I'm going to take that home. I'll think about that one.
So maybe I can take a stab at it just in 15 seconds, but it's in diagnostics, I think AI can play a role. So spirometry, like there's a way of, improving using AI models to interpret that data, and the other one is in imaging. So with the processing of X-rays or CT scans and so on, I think these are ongoing efforts.
Let's thank our speakers, and I will.